Okay, welcome you all at the Satellite Symposium of 27th TCTAP 2022, Reach for PCI Optimization, organized by CVRF and supported by educational grant from Abbott Medical Korea. First of all, I'm very happy and honored to have a distinguished panel here. So Sang-Wook Kim and Takeshi Kubo, Chang Lee, and Ching Chen Woo is my old friend here. So really thank you for joining us. And so we have three main issues for this satellite symposium. So short depth for in high breathing risk patient and OCT issues and FFR issues for us. And then we're gonna start the first lecture. Dr. Oh Gyuchol from the Catholic University of Korea, Seoul St. Mary Hospital. So he will give us a short depth in HBL patients. All stain created equal. Dr. O, please.
Thank you for the introduction. I'm Gyuchol from Seoul St. Mary's Hospital, and today I'll be talking about short depths in HBR patients. I'll be mostly emphasizing on the role of stents here. I have nothing to disclose. Today's contents, first, I'll briefly go over some current issues in antiplatelet therapy after PCI. Then I'll be talking about the optimal DES, emphasis on the stent polymers, why they matter. And finally, I'll show you the results from the Science 90 and 28 trials, which have shown in patients with HBR and DAP duration. Okay, so we all know that dual antiplatelets are key components in preventing ischemic events after PCI. However, they inevitably bring about bleeding. Furthermore, recent patient trends in PCI show a high prevalence of HBR, high bleeding risk patients, probably due to an ever-aging society. When bleeding occurs after PCI, the physician will need to reduce or stop antiplatelet therapy, and this has shown to lead to an increase in ischemic adverse events. So recent trials on antiplatelet therapy have mostly evaluated a shortened or a less intensive regimen. However, there has yet been an optimal DAPT regimen set for HBR patients. In recent years, we have seen trials that have shown that de-escalation, whether it be in duration or in intensity, did not differ in net clinical events. In the TICO trial, dropping aspirin 3 months after PCI reduced bleeding while having no difference in ischemic events. In the Talos AMI trial, switching from ticagrelor to clopidogrel at 1 month after PCI showed both improvements in bleeding and ischemic events. The benefit of shortened DAPT is that it reduces bleeding events. So why is bleeding so important? The ARC HBR criteria here defines these factors as having increased risk of bleeding. You can see here in the upper left corner that age itself is a high risk of is a bleeding risk. It says here that 75 years or older may cause increased risk of bleeding, but we are aware that patients we meet in the cath lab are getting older and older by year. Some days, all patients in a day may be over 75. So how prevalent are HBR patients? In a single tertiary center in the US, almost half of patients qualified as HBR according to the ARC HBR criteria. And these patients also have a significantly increased risk of all-cause mortality and myocardial infarctions, suggesting that the current practice we're doing right now might not be really optimal, that something may need to be modified in these patient populations. Next, on to the DES. It has been now over 40 years since we started performing PCI. At first, it was just a matter of getting the RA open with plain old balloon angioplasty. Next, bare metal stents were used to eliminate elastic recoil and keep that artery open longer. However, bare metal stents did not guarantee the long-term patency we favored. So drugs were coded on and rising of the drug-eluting stent era. Ironically, the initial DESs decreased their stenosis rates, but had issues with early thrombotic events. We took care of that with dual antiplatelet therapy. However, now with those newer generation DESs, we want more flexibility in our DAP use. We all know how good current DESs are. We use them every day. We don't have really big issues with them. However, there still are some remaining issues. First, stent failure rates are not zero. There are up to 4 to 5% target lesion failures at 1 year. Next, late stent failure issues. Those after the 1 year neoatherosclerosis and stent fracture, there are still those remaining. DESs also require that to decrease the ischemic side effects, but they inertly increase bleeding side effects. So to decrease side effects, we get another side effect. And this could all be a risk for higher risk patients, especially in HBR patients. What would an optimal stent look like? What would an optimal stent need? I'm surprised that no one just has not used Optimal or Optimus as a stent name yet. And anyway, an optimal stent would need good deliverability, good uniform deployment and radial strength. It should minimize early thrombotic complications, prevent restenosis, and have minimal inflammation effects. Among these, antithrombotic, preventing restenosis, anti-inflammatory effects have some relationship with the polymer of the stent. When we put a medical device into a body, these factors, factor 12, platelets, thrombins, fibrins, they will induce thrombus formation in that device. That's why we load patients with antiplatelet therapy before PCI. However, with polymer-coated DESs, the polymer coated on top of the medical device surface can modify the surface of a stent to a more thromboresistant environment. The factors in thromboresistance of a stent could arise from a thin strut design and minimal flow disturbance, or the polymer used in coating the stent. The polymer may be durable. They may stay on the stent forever, or be degradable, may disappear with time, or there may be none at all. It could be conformal. It could go all around the stent strut, or it could be abluminal. It could be only on one side. As you can see in this slide, which probably many of you have seen before, the Xience and the Resolute stents have used a durable polymer, while other well-known stents such as the Biomatrix, the Ultimaster, the Synergy, the Cyro stents have a biodegradable polymer. So then what does the polymer do? The polymer of a DES is a drug reservoir for controlled release of the anti-proliferative drugs, which ensures anti-restenotic efficacy. However, in the earlier first generation DESs of Cypher and Taxus, these polymers had poor biocompatibility and increased the risk of thrombosis and localized inflammation. In the newer generation DES, the polymer was one of the first to be modified. The modification went two ways. One was a biocompatible polymer, which was a highly fluorinated polymer, the photopolymer of the Xience stents, or the BioLinks in the Resolute stents. The other stents went on to make the polymer disappear after a certain time, the biodegradable polymer. You can see here that in the initial, in the first generation DES of Cypher, there are very many inflammatory cells near the stent cells. But however, in the Xience stent, there are less inflammatory cells. Then are polymers really important? An animal model of DS implantation here shows that after a month after stent implantation, endothelial coverage is only around 50 to 60%. So favorable blood biomaterial interactions are very important, especially when you're thinking about a short TAP regimen. This is from a very old animal model from over 30 years ago, showing that albumin, which is in our body, shows an inert thromboresistant effect. In an ex vivo canine model, PVCs pre-absorbed with albumin showed less thrombus formation at the time compared to those pre-absorbed with fibrinogen. So you can see here these thrombus formation, but none of them when the PVC is pre-absorbed with albumin. The fluoropolymer that I've talked about before on the Xience stents actually increases the absorption of albumin after deployment, leading to less monocyte adhesion compared with bare metal stents. So they are very anti-inflammatory and anti-thrombotic. When compared with other DES and bare metal stents, the Xience stent shows the highest intensity and coverage of albumin here, which was a fluorotag. You can see here that with time, other stents have maybe get lower albumin intensity signals, but the Xience stent shows a significantly higher albumin binding. When you look at this more carefully, there's a uniform coverage of stent struts, unlike other DESs or BMS. This high absorption of albumin may lead to the following results. In an ex vivo swine model, after deployment and use of aspirin monotherapy, science stents on the left here show a very significantly lower platelet adhesion compared to the Synergy, Osiro, even the Onyx stents. You can see here that in the red here, all the platelet adhesions you've seen, but not so on the Zion stent. And also significantly less inflammation as seen here by lower neutrophils and monocytes accumulated in the stent near the peristent struts. These findings are also true for clopidogrel monotherapy, showing similar results in platelet adhesion here and in inflammatory cell recruitments. So then, which one's better? Is biodurable stents really better? I won't be the one to say which one is the winner here yet, but I don't think there's a clear answer yet. Recent trials that have compared durable and degradable polymer stents have shown a bit mixed effects. The BioSTEMI trial on the left here shows favorable outcomes of target lesion failure in the degradable polymer group, which is the blue line here. However, in the more recent host RP ACS trial, they showed similar patient-oriented composite outcomes of POCO, but for device-oriented outcomes, there were a little bit more significantly more favorable outcomes for the biodurable polymers, which is shown here in blue. Finally, I'll show you the results from the Zion short TAP programs. The Zion stent has been used in many trials that have used shortened TAP regimens. It has also shown results both for aspirin monotherapy and P2Y12 inhibitor monotherapies. The Zions 28 and the Zions 90 trial compare the efficacy and safety of shortened TAP regimen of 1 to 3 months in high bleeding risk patients undergoing successful PCI with Zion stents. An ischemic endpoint of all-cause death MI and BARC 2 to 5 bleeding and stent thrombosis rates were compared with a historic control from the Zions 5 study. The Zions 28 and the Zions 90 included high bleeding risk patients using the ARC-HBR criteria. To go over them, aged over 75 or more, chronic oral anticoagulant therapy, chronic kidney disease, anemia, platelet counts below 100,000, major bleeding in the past year, and history of stroke. They excluded patients with STEMIs, LV dysfunctions, EF below 30%, overlapping stents, and left main ISR, CTO, and graft PCI patients. The Zions 28 and the Zions 90 trial included a total of 3,600 patients globally. After successful PCI with the Zions stent, patients were maintained on that for 3 months for the Zions 90 trial and 1 month for the Zions 28 trial. After that, patients were maintained on aspirin monotherapy. Both groups, the 90 and the 28, showed comparable event rates of all-cause death and MI compared with the Zions 5 population, while showing significantly lower rates of bleeding, especially for those major bleeding of part 3 to 5 bleeding. There was a significantly lower bleeding rates in both the Zions 90 and the Zions 28 populations. And also stent thrombosis rates were also very low. When we compare between the Zions 28 and the Zions 90 patients, the rates of death and MI look very similar here, regardless of the time point. But bleeding events are significantly lower in the Zions 28 patients. This means that for HBR patients without bleeding events up to 1 month, 1 month regimen may be favorable compared to maintaining that for not additional 2 months. You can see here that after 1 month, those on the Zions 90 program, which is a 3-month step, do have an increased risk of part 2 to 5 and also part 3-5 bleeding here. Next, we talked about the aspirin monotherapies trials. I'm going to talk about the P2Y12 inhibitor monotherapy trial, the STAP-TAP2 and the STAP-TAP2 ACS. These were different trials, but they have a STAP-TAP2 total cohort analysis that I'm going to show you. These patients, the dual antiplatelet therapy was maintained for a month, and after that, one group showed remained clopidogrel for the rest of the time, while the other remained 12-month TAP. The primary endpoint, a composite of cardiovascular and bleeding events, and also TB major and minor bleeding were observed. For the whole cohort, the primary endpoint of net clinical benefit was similar in the 1-month TAP and the 12-month TAP group, while bleeding events were significantly lower in the 1-month TAP group. Among these TCTAP2 total cohort patients, there were about 30% of HBR patients. So in these patients, let's see how the outcomes were. Unlike the Zions 28 and 90, which recruited mostly high HBR patients, these patients have a little less major criteria, and mostly they have a minor criteria of bleeding risks. The subgroup, you can see here in the subgroup analysis that the cardiovascular endpoints, there are no differences among the 12-month TAP and the 1-month TAP group. But for in the bleeding endpoints, especially in the high bleeding risk group, 1-month TAP showed a significantly lower risk of bleeding here. For the HBR and non-HBR, there were no, the interaction of p-value was above 0.05, but there was still a numerically lower rate of bleeding events in the HBR group. To summarize, among HBR patients undergoing PCI with Zion stents, a short TAP regimen showed non-inferior ischemic outcomes and showed a significantly reduced major bleeding events. However, these trials are all non-randomized clinical trials. For the Zions 90 and 28, they compared with a historic control group. For the TCTAP2 total cohort, HBR analysis itself was not a randomized clinical trial. So who gets the credit or who gets the blame? It could go both ways. Are these excellent results due to the stent itself, or are we performing better PCI than before? Is there room for improvement in DSS? Can they get better? Is there room for improvement for us? Luckily, our next speakers probably will tell us how we physicians can improve using imaging and physiologic assessments. I'll conclude with this slide. We know that prolonged antiplatelets cause bleeding, so a short TAP regimen may be favorable, especially in HBR patients. DSs are not all created equal, and polymers have evolved to be more biocompatible and thromboresistant. The Zion stent with its fluorinated polymer have shown to be safe to use with the short TAP regimen. Thank you for your attention.
Great, very much a comprehensive review, and we want to move to the second lecture. Dr. Kim Young-chul from Yongin Severance Hospital. So he will give us how to have a fun dive into the OCT A2G. Dr. Kim, please.
Thank you, Chairman. Today, I'd like to talk about how to get the fantastic OCT image. Let's have a look at the guideline regarding the intravascular imaging modality quickly. In 2014, OCT guidance may be considered for stent optimization, although IVUS guidance should be considered for stent optimization. However, with many evidence regarding the benefit of OCT-guided PCI compared with angio-guided or IVUS-guided. So guideline has changed that OCT should be considered for stent optimization as same as IVUS. This graph regarding the annual trend of image-guided PCI in patients with AMI in Korea, not all ischemic heart disease, but we can assume the operator preference regarding intravascular image modalities. After changing the guideline regarding OCT since 2018, do you think that the use of OCT is increasing? Definitely no. So why is this trend happening? In the technical aspect, I think that only one further step when we perform the OCT, so contrast injection, and it can lead to the interfere with being familiar with OCT compared with IVUS. So as an intravascular imaging modality, concept of OCT is same as IVUS. However, in terms of technical aspect, concept of OCT is totally different from the IVUS because of contrast media, injection, and IVUS only need to push the pullback button for the image obtaining, but OCT has the further step regarding the getting the OCT image. Step 1, press the live button for the OCT activation. Step 2, press the auto calibration button for the catheter flushing. Step 3, press the enable button for the being ready to the OCT catheter pullback. And the final step is to press the pullback button. And in addition, so the contrast media injection is mandatory between the step 3 and the step 5. So important question is that who is dealing with the all things of intravascular imaging modalities? I guess that is most of the stuff is taken by IVUS or OCT machine handler. Compared with the IVUS, serial step including contrast media injection are machine handler's burden, and it could lead to the having a difficulty of circumstance regarding OCT guided PCI and making a gap between the guideline and the practice regarding OCT use. So what is the key to successful settle down the OCT in CASRAP? In my personal opinion, we need to think different. Number one, CASRAP team approach is mandatory for the OCT guidance. In addition, my personal opinion, so Abbott should provide a very detailed and practical manual for the OCT guidance. If not, it is very, very difficult to have an increasing of the OCT use. This slide you are looking at is the normal circumstance during the OCT pullback in our CASRAP. And you can see the OCT machine handler only prepare the contrast media injection, and most of the stuff for the OCT pullback is taken by operator using DOC. Moreover, after OCT pullback and the successful OCT image obtaining, operator easy to look through the fantastic OCT image to have a plan for the OCT optimization using joystick. And all CASRAP team can enjoy the fantastic OCT image without any burden of stuff. So imaging interpretation is important topic, but on this presentation, I'm talking about technical OCT basic to enjoy the OCT resolution, which can make a stent or PCI optimization. So what is the top priority to get nice OCT image? It is definitely blood clearing. So it is most important step to start OCT guided PCI optimization well. So I'd like to talk about the number one, guiding catheter selection, and number two, how to inject contrast media well. Theoretically, any type of guiding catheter are okay, but if you want to the first step for the OCT, I would recommend that JL for the distal left main OCT and the EVU type for the LAD or left circumflex artery, including proximal region, and the RCA EVU type or short unplugged left type for the RCA. In addition, I would recommend the 6 or 7 French guiding catheter, and I strongly recommend the guiding catheter without side door should be mandatory. If the side door is necessary for the perform the PCI, such as the left main disease or RCA ostial lesion, we don't have to use the OCT because we also have the very promising another good intravascular modality called IVUS. So this is the example of contrast injection using guideline catheter with the side hole. Due to the getting the contrast out through the side hole, you can't enjoy the fantastic OCT image, but only have a look at the blood swelling on the OCT. Lastly, to make sure to engage the guiding catheter. So always check the whether guiding catheter engages well or not before the contrast media injection. Let's move on to the how to inject contrast media well. So there is no doubt that auto-injector pump almost should be considered if you are not a master of OCT. When you set up the auto-injector, do not exceed the 300 PSI, because it's a high PSI lead to the washout the contrast media into the aorta due to the immediately pressure up. So we set 250 PSI for pre and post-stenting PCI in our center. Regarding the contrast volume, the basically total amount is 16 cc during 4 seconds. And understanding of OCT catheter structure is important to perform the successful OCT-guided PCI. There are 3 markers I call the distal marker, lens marker, and the proximal marker. So we should know the 2 lengths, 26 millimeters between the distal and the lens marker, and 50 millimeters is between the lens and the proximal marker, which is true length of the OCT pullback. And more concentration should be taken when you perform the OCT for in the far distal, especially left circumflex, because the OCT pullback always need the further 26 millimeter between distal and the lens marker. And make sure the 3 markers, and remember 26 millimeters and the 50 millimeters, which is the basic pullback, OCT pullback length. And then we just choose the 54 millimeter or 75 millimeters pullback depending on the lesion length. And another personal tip on achieving good OCT image is that don't forget to intracoronary injection of nitroglycerin or nicorandil before the OCT catheter injection to prevent from the vasospasm. And next is the catheter flushing is mandatory by contrast, not saline. And number 3, click the auto calibration after catheter flushing and recheck the guiding catheter engagement before the OCT pullback. In my early phase of the OCT experience, it was happened sometime, as you can see, OCT pullback was done without contrast media injection. So don't forget to open the OCT contrast line. In our center, cath lab team always double check the OCT contrast line. There are very difficult cath labs, very different cath lab situation in each country. OCT pullback process is conducted by OCT handler in most of the hospital in Korea. However, it would be big pressure for the OCT handler, as I mentioned before. So in our center, we are doing OCT pullback using the DOC, as you can see, mainly leading by operator. So it is a very easy system. So just 1 click the white button on the DOC and 3 clicks green button on the DOC. So in need to the OCT handler is happy with just 1 shot of the contrast media. So let's have a look at how to get the fancy OCT image by operator. So you can see the button box called the DOC. It enables operator to control the very single step of OCT image acquisition, not OCT machine handler. So first step is just press the live button, and then you have to get the catheter flushing for the blood clearing inside the OCT catheter by contrast media, not saline. And the next step is only press the green button to get the auto calibration. Then OCT handler get involved only 1 time in the OCT pullback process for the injection of contrast media, only 1 time. So next time is just press the green button twice to get the fantastic OCT image. So in terms of operation aspect, number 1, make sure to open the contrast line from the auto injector to guiding catheter. And number 2, make sure the guiding catheter engagement well. And number 3, press the live button and then conducting the catheter flushing by contrast media, as you can see. Number 4, very important step is that make the straight the OCT catheter and holding the Y connector, wire, and the OCT catheter and OCT pullback. Then you can enjoy the fantastic OCT image and the very useful OCT functions such as 3D rendering, standard position index, and the co-registration and the automatically measurement of a minimal stent area. So this is last slide on my presentation regarding the suitable guiding catheter, no side door, and the 6 French or 7 French would be recommended. And always prefer auto-injector pump and double check the OCT catheter 3 markers and remember the length of between markers, and intracoronary nitroglycerin or nicorandil is mandatory, and the catheter flushing should be taken by contrast media, and double check the guiding catheter, and just 1 click the white button and 3 click the green button on DOC. And the most important thing is that all these stuff for the OCT should be conducted by team approach, especially by operator. Thank you for your attention.
This is Jung Min from Asan Medical Center. My topic is FFR is routine cath lab procedures. In my cath lab Asan Medical Centers 2021, our center is the Imaging and Physiology Center, the cath lab. Our 4 cath labs for coronary procedure, we did 6,000 coronary angiogram, 2,000 PCI, 2,000 intravascular imaging, and 1,700 FFR in 2021. So we measured a lot of FFR in our daily practice. From when? After the phase 1 trial was published in the New England Journal of Medicine, before 2008, 2009, we never measured FFR in our cath lab, but after phase 1 trial publication, 2010, 2011, we measured FFR as many as we can if there is no evidence of ischemia prior to PCI. The overall period that we used the IVUS very frequently. At 2011, almost all cases was done by the IVUS guidance. In 2011, FFR penetration rate is up to 50%, so very high rate of FFR penetration in the world. I think it's the highest number, highest percentage of FFR penetration rate. Our high FFR penetration rate was based on the several important clinical trial and observational studies. First of all, the phase 1 trial demonstration that the benefit of FFR-guided PCI in the multivessel disease. At 1 year follow-up, the FFR-guided PCI demonstration that the lower event rate regarding the MACE compared with the angio-guided PCI, but the 5-year follow-up, p-value became insignificant, but the overall trend, low rate of MACE up to 5 years was consistent in the FFR-guided PCI. More importantly, FFR-guided PCI showed the numerically low event rate with almost 30% reduced number of stent use. This is very important, to reduce number of stent use, but the favorable long-term outcomes. In addition, phase 2 trial demonstration that FFR is less than 0.80, coronary stenting was justified to reduce the urgent revascularization, and mainly urgent revascularization. In addition, different trial long-term clinical outcomes show that FFR is more than 0.80. Different trial used the cutoff value of FFR 0.75. So the long-term follow-up showed that the different lesion outcome was very favorable. So this is the current guideline, ESC guideline 2018, ACCH guideline 2021. FFR measurement in the intermediate grade stenosis was considered as class 1A indication. More importantly, I think in stable patient with angiographically intermediate stenosis, FFR negative or IFR negative PCI should not be performed. This is I think this is more important than the class 1A indication. Then how can the FFR measurement be a routine procedure in our cath lab? Our first step is we admitted the visual functional mismatch between the coronary angiogram and FFR. We measured FFR as many as we can, so we found a larger visual functional mismatch case. The angiographically tight, but FFR is negative. In addition, we measured the IVUS. IVUS is smaller than previous cutoff value at minimal lumen area for O, but the value spec was negative. So we realized that the visual function is a very frequent instance of visual function mismatches. So we can move from the angio-based decision making to the FFR guided decision making. This is an instance of visual function mismatch. For left main cases, the 70%, 35% mismatch, 40% reverse mismatch. Now left main disease, 57 mismatch, 16% reverse mismatch. So even left main or non-left main, the 60% coronary stenosis show the visual functional mismatch. So next step would be we made the outcome drive the revascularization threshold. Contemporary cutoff value 0.75, current cutoff value 0.80. This cutoff value was derived from the non-invasive functional study, but we want to make outcome driver revascularization threshold in the real world practices. So we made the IRIS FFR registry. We gathered the 5,800 patients. The 8,000 lesions was FFR was measured in the 8,000 lesions, different in 6,000 lesions, revascularization in 2,000 lesions. So regarding cardiac death, MI target vessel revascularization, the revascularized the event rate is red line and default event rate is blue line. So two lines was intersected at the point of 0.75 FFR. So this cutoff value was very similar to the contemporary cutoff value FFR 0.80. So based on the outcome data, we supported the contemporary cutoff value of 0.80. So we became more confident to use FFR cutoff value of 0.80. More importantly, regarding the cardiac death and MI, cutoff value was 0.64. So 0.80 cutoff value is very safe, differing the revascularization in any stenosis, regardless of severity of stenosis. This is a real demonstration that the long-term clinical outcome in lesion with the gradient FFR. In the gradient FFR, very interestingly, default lesion, revascularized lesion outcome up to 4 years, there's no difference. So between the 0.75, 0.8 gradient, so personally, I prefer the default, but based on the clinical judgment, so some lesions could be the default, some lesions could be the revascularized. Even though FFR cutoff value 0.80, more than 0.80, we should default. We should not perform the coronary revascularization. The next, in addition, we also evaluated our registry, the ASAM PCR registry data, how improved the FFR guided PCI, how much improved the clinical outcomes. As I showed before, that the FFR used in our centers after 2010, we measured FFR as many as we can in our daily practice. Regarding cardiac death and my target vessel revascularization, after routine use of FFR, the event rate in our contemporary, our daily practice patient, event rate was reduced significantly, 41%. width. Between the two periods, the lesion number, there is no difference, but the stent number used in daily practice reduced by 29%. Which lesion less treated before and after the RCA and circumflex? Stent number reduced more significantly because RCA and circumflex subprime myocardium is smaller. So even though there is a tight stenosis angiographically, FFR could be a negative more than 0.8 or frequently. So RCA circumflex less treated. And this is important because RCA circumflex subprime myocardium is smaller than 8 than left main. So let's stenting makes sense. So in detail, cardiac death, no difference, but the myocardial infarction significantly reduced after routine use FFR, mostly due to the reduction of peri-procedural myocardial infarction. In addition, repeat intervention also reduced, mostly due to the reduction of target vessel revascularization, target lesion revascularization. So we found that the benefit of FFR-guided PCI is primarily due to the reduced number of stents per patient and subsequent decreased risk of peri-procedural MI and repeat intervention. So we found the clinical benefit based on our daily practice. So we can measure the FFR as a routine our cath lab practice. Recently, the ischemia trial published that. So what is the role of FFR in the post-ischemia trial? I think the FFR measurement would be the minimum requirement to the coronary stenting, because in the ischemia trial, even though there is at least a moderate ischemia, coronary stenting or coronary revascularization cannot improve patient survival. So if there is no ischemia, I believe that stenting is not justified. So no ischemia means no FFR or no IFR. So if IFR or FFR is negative, the stenting is not justified. Please do not perform coronary revascularization. This is my final summary. FFR or other coronary physiology has a sound scientific basis. Code of value was initially validated against the ischemia test and thereafter clinical outcomes. FFR might be considered as a clinical index in revascularization decision making rather than the simple physiology indicator of ischemia. In addition, FFR-guided PCI was validated in the random trial and real-world registry, favorable outcomes with the less stent use. This is very important. In post-ischemia era, FFR positive, FFR less than 0.80 would be a minimum requirement for coronary stenting and revascularization of stenosis. With FFR more than 0.80 is never justified. Unless a new standard emerged and new data redefined the role of FFR, FFR should be measured in everyday clinical practice as a routine practice. Thank you for your attention.
And so I would like to stimulate it, for the discussions in terms of FFR part. I prepare, several slides. Why FFR? FFR concerning our routine cath lab procedures. So main issue is there are many mismatches between the angiographic post-diameter stenosis and FFR in real-world practice. That is typical examples. 85 stenosis by angiographically, however, 0.8 for negative FFR. There are clear visual functional mismatches. Look at this, 85% tighter stenosis, however, negative FFR 0.84, negative, all negative non-invasive stress test. It's normal volume, normal stress echo. So I became a FFR believer. Look at this, FFR guided PCI clearly ischemia-guided procedure. Surprisingly, if you look at the history of angiographic post-diameter stenosis, actually has no ischemic threshold by itself. Just only angiographic post-diameter stenosis always should be supported by non-invasive stress tests to define, evidence of clinical ischemia. Why mismatches? Angiographic post-diameter FFR. If you look at the FFR, mainly determined by degree of stenosis, size of myocardium, and region-specific morphologies. This is very important slide. Look at that. Different morphology concern. Exactly same degree of stenosis of 50%. However, different morphology, region morphology can make a different FFR, right? And so we clearly demonstrate another very important factor is that, surface roughness concerns the smooth one and very tough roughness, depending on a different screen size is 50, exact same percent of diameter, so it's 50%, however, totally different FFR. So degree of stenosis, size of myocardium, and region-specific morphology can make a FFR. Look at this, how many mismatch there is main issues in real world. This is a study data, more than 1,000 lesions. Look at this, angiographically 50 to 70%, among them 65%, of cases are negative FFR, even 70 to 90%, 20% negative FFR, overall 43% from the angiographic diameter stenosis 50 to very tight stenosis. Look at this, that is our data. More than 50% significant stenosis, among them negative FFR, maybe 50 to 80% stenosis, almost 57% of mismatches and 16% reverse mismatch. Conclusively, among the intermediate stenosis between the 50 to 80% angiographic diameter stenosis, among them, more than half of them are negative FFR. The meaning is we cannot define, ischemia in terms of a clinical ischemia by angiographic pulse and diameter stenosis between the 50 to 80%. And so you know that current guideline FFR in the last year's 2021 ACCA guideline change is clear, class 1A. If you look at any guideline, without evidence of FFR positive S3B indications, so currently last year's ACCA guideline is actually saying negative FFR PCI should not be performed, the 3B indication. And so it is clear, rule 1, positive FFR, okay, we can treat them. Operator discussions, you have idea about the ischemia studies, 1 vessel, 2 vessel, depending on your decision. However, positive FFR is definitely ischemia guided procedures. However, negative FFR don't touch, right? There is no evidence of any clinical ischemia patterns. And so in our practice, I would say visual estimation 50 to 80% without evidence of non-invasive stress test. We have to definitely consider FFR, and multivessel disease evaluation also we need FFR. And so in order to avoid unnecessary procedures, improve the clinical outcomes, and save the money, we have to do FFR first. All right, this is very brief, several slides for simulating discussion in the later. Okay, it's time to discussions. Dr. Wu, my old friend. All right, what about you? Discuss and the stimulating.
I guess Dr. Kubo had a lot of experience using OCT. So optimization, I think I like to raise one question regarding, for me, in my lab, it looks to me imaging guidance, IVUS versus OCT should be similar, only has some rare situation, for example, OCO, CTO more favoring of IVUS imaging. So, but technical, I think that can be improve, if you are familiar with that, all team familiar with OCT. Even sometime with the nighttime, we have AMI cases, we do OCT routinely at the midnight. So what is your suggestion? How to familiar with that whole team to all OCT machine?
So thank you very much. It's very important question to spread their OCT use in our daily clinical practice. So I totally agree with you that Yong-Cho Kim's opinion. We should make our imaging team, I mean the most mostly in our daily clinical practice, technician will play a lot of work in the imaging guided PCI. So training and skill up of the technician is very important, very key issue to use OCT imaging. And actually, in our daily clinical practice, physicians insert the OCT catheter in the coronary artery, and then technician prepare and done the OCT imaging. So the stress and work of the physician is very small in the OCT guided PCI. Thank you very much.
Thank you. So may I ask Dr. Park regarding the ASAM Medical Centers, OCT versus IVUS, how is the percentage between two imaging modality?
All right. Up to this point, we just finished our OCT versus studies, meaning is OCT versus IVUS guided procedures, and so 50-50. Says just finished our study. We will have a little bit of answers. All right. I got a very simple, direct questions, Dr. Kim and Dr. Gubodos. Why we have to consider imaging in the intervention cardiology? Why, from the imaging studies, what is the most important index to change the procedures, right? Just one or two, variables. What do you think, Dr. Kim first?
Thank you for your big, difficult questions. So in my just opinion, is that
Yes.
Coronary artery is the 3D, not 2D, but is the angiography. We just see the coronary artery by 2D, but this the intravascular image is provided is the 3D, is more reality of the coronary artery is the circumstance such as the lesion characteristics or lesion morphology. So I think is that leads to this ASAM Medical Center conducted is many study regarding the IVUS. So it's most of these study lead to the positive effect of intravascular image, especially IVUS at this moment. So I think is we changed this concept. Is coronary artery is the 3D 3D model, is not 2D. So that's why is the intravascular image is mandatory to perform this PCI optimization. So among the IVUS and the OCT, so is the preference is I think is the operator just the preference lead to the select is the IVUS or OCT. I don't want to fight is IVUS against the OCT because it's in the general concept is the intravascular imaging modality included IVUS and OCT, but it's my preference is at this moment OCT, but we need more data. OCT is whether OCT should give the better clinical outcome is for the patient.
I also have a comment. As Dr. S.J. Park said, there is a big discrepancy between the angiography and the FFR. And also there is a big discrepancy angiography and the intravascular imaging findings. So for the determine the clinical and PCI indication, FFR is useful. And optimization imaging might be useful. So minimum standard area is a very, very strong and independent predictor of the future coronary events. So we would try to use recommend to use the intravascular imaging in your daily clinical practice. Thank you.
Great. What do you think, Sang-Wook, Dr. Kim? Right, you are almost to be a senior, right, for the imaging field. So would you comment on that?
Thank you very much for the great talk. Yeah, I prefer to use intravascular imaging better than more than FFR. The imaging tool provide a more clear clue before the scan, after the scan. I think it's really important to improve the outcome for the PCI. And also, I also prefer to use the OCT with a high resolution. But as the Dr. Kim mentioned before, main hurdle to use the OCT is the contrast injection. We need one more step for the contrast to clear the blood inside the vessel, and also we need to connect the injector to make a better imaging. In these cases, I prefer sometimes I often use a saline or dextran without injector. We have some protocol to make a clear blood clearing with the saline and dextran. It makes it better. Sometimes we can get a clear imaging without injector. What do you think about saline or dextran use for the blood clearing? I think it's the main issue, main hurdle, not to increase the use of OCT. How to improve or overcome the hurdle? What do you think about Dr. Kim?
Yeah, thank you for your comment. So I think it's the earlier pace of OCT experience. I think is the auto injector is the mandatory because it's the to optimize the to get the best fantastic OCT image. But it's the like you is the master of the OCT. So and at that time is the saline or dextran by the manual syringe would be okay, but for me is I always almost prefer the auto injector even in the night time is the AMI patient. Yeah.
Okay, Dr. Jang Lee, also comment and have some discussion points.
Yeah. Basically, I agree with the concept, Professor Park, the concept, PCI decision by FFR and PCI optimization by imaging guidance. However, sometimes, very sometimes, I wonder how to do when the FFR is negative. Are there any role of imaging study in that patient to do or not, to treat or not treat? How do you think about that, Professor Park? I really wonder your opinion. FFR in the FFR negative region, what is the role of imaging study, or treat or not treat?
FFR, you mean FFR negative?
Yeah, the region FFR is negative.
Right, absolutely. Just leave it alone. Don't touch. That is our, many and not too much data. However, based on the 아주 solid data, you clearly show that the class 1A, there is, kind of a general, perception, general agreement of at least we have to decide to treat or not to treat, ischemia guided or not. You have to depend on FFR rather than angiographic post-and diagnosis. That's the point. Up to
yeah. So, but there are some efforts to do preventive PCI for vulnerable plaque. So in the image study, there is some vulnerable plaque. But
all right, great.
But how do you think about the effort to study?
All right. So we have no answer clear, right? And in terms of a vulnerable plaque concept, it changed a lot from the last 10 years. You're gonna start almost 2005, 2006 for the invest vulnerable plaque. However, recent years, that lots of aggressive anti statin statin treatment, ACE inhibitor treatment, high dose of statin, etc. So we have to change is, aggressive medical treatment can, be able to change its, natural presence of vulnerable plaque. And so we just finished our prevent study. So I don't really worry about that one. However, still, treat vulnerable plaque is too early, right? So just depending on FFR. All right, Dr. Summary with imaging guidance. So I would say clear, even in the OCT, guided, IBS guided. I would say the first thing is stent size. Clearly, we can select the bigger, stent size rather than the angiographic guided procedure. And so we're going to make a big stent areas after the procedure. So we have to optimize by imaging concern. And so select the big stent and big effective stent area can make a good clinical outcome. I think it's clear, right? Between the OCT versus IBS, all right, there are some, delicate difference in terms of syncytial fibroasthma, lipid-rich plaque, some superficial calcification. What do you think? What doesn't matter, right? Just stent it, that's it. Even in the, a vulnerable plaque, you're gonna stent it, adjust it, right? So, imaging concern, I would say important thing is stent size. That is the most important, right? So in the practical issues, so all right, I would finally, Dr. O.
Yep.
We all right. You clearly reviewed a short depth for the different DES, and so what is your there are many data, even in the different DES, as Onyx, Ultima studies, short depth, study. There are clear supported some, 1 month, at least 3 months as HBR patients. And so what is your, practice in current your practice for the HBR patient in, common non-HBR patient? It's just practical point of view.
Okay, from our point, because we had joined the the Zion's 28 study, so I'm quite confident because enrolled in Taiwan patient, we showed DAPD trial only 1 month, then shifted because by protocol I cannot change to like stop DAPD to using we use single aspirin. However, we have some discussion and some debate with Rosanna Marantz. The Asian population seems to be single agent clopidogrel is more favorable for the GI upset. But in our confidence, because our trial patient 100% use imaging guidance, so either OCT or IBIS, and if the standard position is very good, I'm quite confident we can use short DAPD only 1 month, and safety is very good. And even this patient, though none of them have thrombosis issue, we have some instant restenosis, very single digit number. But I think this is a good way. For example, high risk bleeding patient, we should go short DAPD. But of course, durable polymer. Current Zion's, fluoroscopy, fluorence, the polymer, it shows that, thrombo resistance. So this is maybe another factor. So in my practice, I prefer to use, this kind of DS and also combine because of data show DAPD in our practice. Thank you for your questions.
What about Japan, Dr. Bubu?
Yes, thank you so much. Mainly, I consider 3 months DAPD is a common, and stable patient and the imaging demonstrated a very well expanded results of stent. 1 month DAPD is acceptable.
What do you think, Dr. Kuchel?
For me, actually, I agree with Dr. Kubo. 3 months DAPD, I'm pretty comfortable with the dropping aspirin or clopidogrel at 3 months. 3 months DAPD's okay, but if there's another catch to this, if I am confident of myself of redoing the optimal PCI, if I've done that, I would do the 3 months DAPD. But for the 1 month, actually, I still have some reservations. Even if I did a very good PCI, I wouldn't just go to 1 month DAPD in all HBR patients. If I have to do them, I would be a little bit more confident because of the study results. But I wouldn't, currently, not yet, I wouldn't be doing 1 month DAPD routinely here in my practice.
Okay, any comment?
I think the intravascular imaging making sure for the short depth. What do you think about it, Dr. O?
Yes, I think it's very mandatory for if you're going to do a short TAP, you're thinking of a shorter TAP, or if you're thinking of a de-escalation therapy, you need to optimize your PCI. Optimizing PCI means intravascular imaging, whether it be IVUS or OCTs. And also you want to put in bigger stents, as Dr. Park said. And to do that, you need to do, well, for me, if I want to put in big stents, I don't have the experience of the eye imaging, so I need to see IVUS or OCT. So I think it's very mandatory for HB, especially for those high-risk HBR patients.
Yeah, how about FFR? We don't know about the strut manner of position and also stent under expansion when you're using FFR after stent deployment. What do you think? If you can use the FFR data for the short taps? What do you think about it?
FFR, I'm not, because of for FFR, you can, I think you can a little bit understand the under expansion of stents using FFR, but it's not very, it's very difficult to see how well the stents oppositions are. For those patients, I wouldn't be really confident, currently confident in using a shorter DAPS for. How about other people's opinion on this?
All right, just
FFR guided, optimization is that FFR post, stenting, you can use FFR, of course, but it's not recommended for the short DAPD. So I still not accept this kind of concept. I think, we should use imaging guidance.
Okay. Compared with, after the procedures, stent optimizations, I think the imaging is better. It is possible. And then you can this post FFR is not, greater, not much useful for the, clinical application. The reason why the post FFR, post stent FFR is mainly determined by remaining, GGG issues. Is we cannot touch in terms of, even if we're going to fix, proximal lesion, it's a middle portion lesion. However, mainly post FFR is depending on the remaining DGG issues, peripheral resistance issue, etc. So the meaning is we cannot fix up that. All right. So the reason why in our lab we use really FFR in almost all cases before stent to treat or not treat decision making. However, after the stent procedures, we prefer imaging guided stent optimization is maximal stent areas. I think that is more. That's all that we can do. Even after the stent procedure is low FFR, we cannot do anything, right? That's all right. I think it's a close time. The time to close is really, thank you all, great lecturers, distinguished panelists. You can make a really great Shuttle Symposiums. So thank you all joining us again, and maybe next year's meetings we can meet face to face as I have some fun too together. That's right.
Okay.
Thank you. All right.
Okay. Thank you.
Right. Thank you.
Bye-bye.
Thank you. Bye-bye.
Okay.